put your head back there. So we'll start off scanning the interscalene area. Okay, so to the left is anterior and medial, and to the right is posterior. So just look over that way a little bit there. So I think a really well-recognised technique for interscalene block is to do the traceback technique. So go down first of all and locate the artery, the subclavian artery, and locate the plexus immediately cephallid to the artery, and then basically scan up the neck until the plexus starts to group together. And then you recognise the two scalene muscles and the well-described seagull view. So you can see the brachial plexus between the two scalene muscles, anterior scalene muscle on the left, middle scalene muscle on the right. You can see the sternocleidomastoid over there. You can see the internal jugular vein. Just deep as well, you can see so that's pretty much all. So for an interscalene block, a common approach is to move the target over to one side, and then you have a sonogram like that, and bring your needle in from posterolaterally to anterior medially. So that means the needle trajectory comes across like that. And what I'd recommend is stopping your needle advancement at that point there. So I would stop my needle advancement there. It's not that easy. Okay. And then I'd inject in that point there, hoping to see the brachial plexus move away from the middle scalene muscle. Should you go a little bit higher, in other words, should you scan a little bit higher, the trouble with that is if you scan a little bit higher, then what happens is you start to see the nerve roots go down towards the intervertebral foramina, and here we see a nerve root heading down towards intervertebral foramina here, and that's probably the C6 nerve root, but I'm not 100% sure. It could be the C5 nerve root, but you can see it's heading in towards the intervertebral foramina. So you don't want to be injecting local anaesthetic there. You want to be injecting local anaesthetic when the structures are between the two muscles there. Okay. So that's good for shoulder surgery. Also good for shoulder surgery is to leave some local anaesthetic in this plane here just superficial to the prevertebral fascia and just deep to the sternocleidomastoid. That'll take out the supraclavicular nerve, which is the most caudate branch of the cervical plexus. So you do need to do that to get the cape of the shoulder. So going back down, now go down to the supraclavicular region, down to the supraclavicular region. And we've got this, subclavian artery here. We've got the brachial plexus here. This is the divisions of the brachial plexus. And what you'll commonly see is you'll see a large vessel which bisects the brachial plexus. And this is very frustrating. This is usually the dorsal scapular artery. So you've got to make sure that you look for the dorsal scapular artery, and you can put colour Doppler on. But you mustn't do your nerve block with that artery in view. So you change your image so that either you're above the artery or you're caudate to the artery. This muscle here is the middle scalene muscle, and you don't see much of the anterior scalene muscle. The anterior scalene muscle is basically tendinous, where it inserts into the first rib anterior to the artery. So this is your target, and this nerve block here is good for proximal humerus. It's good for humerus, elbow, and distal surgery. I wouldn't recommend it for hand surgery involving the ulnar nerve distribution, particularly here where the artery is going through the middle of it. I'll come back to the ulnar nerve distribution in a moment. So that's probably enough detail there. I'll just scan up once more, back up to the interscalene view. and just see how those structures head down into the intervertebral foramina. If you scan more medially, you see the thyroid gland, helps you get orientated. Obviously the carotid artery, the internal jugular vein, and the carotid sheath. Another structure you might see is the vertebral artery, which is further down here. So you want to keep away from those structures. We'll just increase the depth to see where we can see that. So this could be the vertebral artery down there. Okay, the other thing you want to identify is that you make sure you identify the rib and the pleura, but basically what I recommend is you just don't go below that line, and for a subclate, for a supraclavicular approach, your trajectory is basically along here, and when you get to this point here, inject some local anaesthetic just at the junction of the middle scalene muscle and the divisions of the brachial plexus. You do have to get into the brachial plexus and spread the divisions apart to get a surgical block. Okay, we'll head down to infraclavicular now. For infraclavicular, I recommend getting the patient to abduct their arm. So if you get the patient to abduct their arm, then the clavicle moves caphalid, and that gives you more space between the probe and the needle when you do the nerve block. So if you put the probe in the sagittal plane, increase the depth so you can see the axillary artery. In this case, left is caudad and right is caphalid, and you can see the axillary artery to the right. You can see the vein caudad. So this is the vein here, this is the artery here, and you've got the posterior cord which sits at 6 o'clock, you've got the lateral cord here. You can't always see the nerves that clearly, but you've got a few options in terms of where you scan. And I said this to my group, one of my groups today. If you scan out laterally, you're going to pick up the subscapularis muscle, which is that muscle down here. If you scan more laterally, then what happens is then you pick up the pleura. And so I don't recommend scanning here, because here's the pleura here, and there's no need to do that, although you can see the posterior cord quite nicely. But if you now scan more laterally, the pleura disappears, and the subscapularis muscle, which is one of the posterior muscles of the axilla, appears. You've got the pec major up here, you've got the pec minor here, and you've got the cords of the brachial plexus having a very reliable relationship to the axillary artery. The next place to scan is in the axilla, and this is where I'll just go back to the ulnar nerve distribution. So for my trainees, I recommend if they're going to do hand surgery that involves the ulnar nerve distribution, just to use an axillary block. So one of the important things to do with an axillary block is to pick up the conjoint tendon of the latissimus dorsi and the teres major, which you can see here. So this is the conjoint tendon here, all the way up here. That's it there. So that's the conjoint tendon, and this is the fleshy bits, the teres major. You only see this if you scan up high in the humerus, because if you scan more distally, it disappears. So the muscle, the lat dorsi only inserts into the very proximal part of the humerus. And this is a very easy block for our trainees to learn, because the median nerve there has a very reliable relationship to the artery. The radial nerve, although you can't see immediately, reliably sits on top of the conjoint tendon of the latissimus dorsi. Often there's a vein there when you let the pressure go, so there's the vein there, and there is the ulnar nerve there. And this is very, very reliable and reproducible. Perhaps the one area that it gets a little bit tricky is finding the musculocutaneous, because the musculocutaneous nerve comes off the lateral cord at various locations, but that's probably it there. And if we track proximally, that should go closer to the artery. Track laterally, it should go out of the muscle. I'm not convinced about that. But so how do we know that the nerves that I said were radial nerve and median nerve are in fact those nerves? Well, the only way to find out is to trace down the arm. So we'll trace down the humerus. We'll start off here. So I'm going to trace the median nerve all the way down next to the artery. So it starts off here. And the other nerve we're going to trace down is the ulnar nerve there. It might be that, start again, reduce the depth. As we trace down, you can still see the median nerve. Median nerve there, which is right next to the artery, has a very reliable relationship, stays right next to the artery all the way down. And that's it there. Trace it all the way down. I don't think the imaging here is that particularly good. The probe probably doesn't match the superficiality of the structure, but that was the median nerve there, immediately adjacent to the median nerve. In terms of the ulnar nerve, it might be the same issue because it's so superficial, but there's the ulnar nerve there, and you can trace that all the way down. There it is there. Stays superficial all the way down, and that's the ulnar nerve there with the arrow. Ulnar nerve comes all the way down, and then it goes behind the medial epicondyle, which is coming into view soon. There's the medial epicondyle. It's gone to the posterior side of the medial epicondyle. So that's the ulnar nerve. Tracing it back up, and then you're very confident where the ulnar nerve is. So for hand surgery involving the ulnar nerve distribution, I recommend that this is a better technique than supraclavicular without the risks. So the radial nerve, I said, was here. So the radial nerve then traces down posterior to the humerus, so we need more depth, so we'll increase the depth. And we want to be able to see the humerus, so the humerus is down here, so we're going to be looking for a structure that tracks down in this way, so we go distally. And sometimes it's not that easy to see because the radial nerve has an oblique course. I'm not convinced I can see it on this occasion, but it does take a course down here between two of the heads of the triceps muscle. We can try that once more, but I won't dwell on it. I'll show you what I would do if we still can't identify the radial nerve. Remember, it has an oblique course, so you might need to rotate the probe a bit, trying to pick it up as it heads down. I think this is it coming into this plane here, but it's really not great imaging for this. And then you can trace it up, but it almost always sits there, right where that arrow is, sitting on the conjoint tendon of the latissimus dorsi. It does not sit at 6 o'clock on the artery. If you have trouble finding the radial nerve, which does happen, and I just showed that there, you can come around this side laterally to the lateral part of the humerus, and left is anterior, and now you're looking for a structure that's coming from behind the humerus. And there's the radial nerve there coming from behind the humerus. That's right on the arrow now. So that's the radial nerve. I'll go proximal. Now it's going behind the humerus. Distal, it's going away from the humerus. So that's your radial nerve there. So if you don't see it proximally, you can always anaesthetise it there, radial nerve. The other structures worth imaging are the ulnar nerve. And I mentioned this morning. And the ulnar nerve you can track along the medial surface of the forearm. First of all, you've got to find the ulnar artery, and the ulnar artery is quite small. In fact, the ulnar artery is tiny, and that's, I guess, one of the things. Reduce the depth right down, and you can see that the ulnar nerve is right medial to the ulnar artery, and as you trace that proximally, the nerve will move away from the artery because the artery goes medial to join the radial artery to form the brachial artery. So as we go distally, though, you can see the nerve comes right back close to the artery and it tracks all the way down. So where would I anaesthetise it? Probably just where the nerve moves away from the artery, which is just there. So there's the artery going deeper, and there's the ulnar nerve there, right where the arrow is. The other structure that's worth anaesthetising or knowing about where it is the median nerve. We've already touched on that. Just straighten your arm there. Straighten your arm completely. So medial is to the left. Medial is to the left, and lateral is to the right. We've got the brachial artery here in the antecubital fossa, and you've got the median nerve there, which is located medial to the artery, and you can trace it back up the arm as we did before, not so successfully, but you can see it there, medial to the artery there. So this is a neat place to do a median nerve block. You can do it right there. Just think about the ergonomics though, because the nerve is on the medial side of the artery, so you've just got to think about how you're going to approach that nerve there. Okay, you can trace the median nerve further down, which we'll do now. So there's the median nerve there. I'm going to centre the median nerve, and we're going to get needing more depth. So the median nerve we're going to track down, and now the median nerve's in the centre there. We need more depth because the median nerve is going to end up between the deep and superficial flexors. So this is the median nerve here. The median nerve at this level has a lot of connective tissue around it, so you do have to get close to it to get surgical anaesthesia in my experience. And that's it there. We can trace it all the way down. Trace it all the way down between the deep and superficial flexors. So I've just got gel in my hand. So that's the median nerve, and we can go back, trace it proximally, and there it is there. It becomes deep proximally. And now it's going to end up on the medial side of the brachial artery. And you can trace it, there it is there, becomes superficial there, and you can continue tracing it up the humerus as we did before. There it is there, tracing it up the humerus. Now it's at 12 o'clock on the artery. That's it there, 12 o'clock on the artery. 12 o'clock on the artery. And trace it all the way up to the humerus as we sort of did before. So again, you can trace there is there. So I might just be losing a little bit. I'll just put the arrow where it is. And that's the median nerve there. Okay, I think we'll move on to lower limb. So we'll do femoral and adductor canal and sciatic. So we'll have to scan down there now. So what we'll do now is I'll move the ultrasound machine over there.